Pastor Philip, you can lead us in prayer starting out, and then I'll make your introduction after that.
Heavenly Father, we, your servants, we pause prior to this webinar to give you praise, give you glory, to express our appreciation for your many, many blessings, opportunities. You continue to build our network, you build our family, our friends, and for that we are grateful. We specifically pray the presence of your spirit upon Dr. Gavin as he shares this very essential health information today with us. Energize him afresh, provide him with a calmness throughout his spirit. Thank you for Dr. Dwight Reynolds, his wife. Pray your blessings upon the Center for Health Promotions operation in its totality. To God, we give you the glory. In Jesus' name, amen.
Amen. Okay, first of all, I want to welcome everyone to our second webinar. And I can think of no one better than to bring in Dr. Gavin to talk about not just diabetes, but he will eventually talk in the future about chronic disease in general. We have been very blessed to have Dr. Gavin, I should say Dr. James Gavin III, MD, PhD, to be a part of who we are. So I just want you guys to hear something. I want to share something with you guys that came from someone that everybody will probably recognize. I want you to see this real quick. Jim does not necessarily want us to be paid because he's a pretty humble guy. I'm kind of humble too, but when it comes to this, hey, can y'all see that? Oh, hold on a minute. Let me share. Let me do something first. I got to do a screen sharing here. Share. Okay, hang on. And I just click the share and share. So you guys people see that? Do you see that? Does everyone see the picture?
Yes.
Okay, great. Here we go.
We owe you a debt of gratitude for your tremendous leadership.
Let me start it over again. Here we go.
Jim, we owe you a debt of gratitude for your tremendous leadership in our work to build a healthier future for all of our children. After 10 years of supporting this organization and making it what it is today, your presence will be missed, but your impact will be felt for generations to come.
Okay, so I thought that would be nice to share that with y'all. I'm not sure if y'all recognize who that was. I have a general idea in terms of who she is, okay? And I'm really over the moon, but God has surrounded me with so many strong and powerful people. As I tell everyone, and I'm sure my entire team knows this, that I always tell people this, that a good leader is not necessarily the smartest one in the room, typically is not, by the way, but it's who you surround yourself with, right? So God has shown me favor, and you know, favor ain't fair. Favor ain't fair, right? To be surrounded by so many great people. And Dr. Gavin is one. He joined CHP's team several months back, and he is totally committed to the cause. So again, without any further ado, I don't want to take any time away from Dr. Gavin. I want Dr. Gavin, I want you to just give a brief introduction in terms of who you are, basically, a little bit of your background. Listen, if you Google Dr. Gavin's name, it's like, it's a book in terms of his curriculum vitae. So here we go.
Well, thank you very much, Dr. Reynolds, and good morning, everyone, and thank you so much for joining us in this webinar. I'm generally quite reluctant, or at least hesitant, to do a lot of introduction about me, because I always assume that people have tuned in to hear from me rather than about me. But because my chief has said I need to do something in terms of some introductory remarks, I am James R. Gavin III, a native of Mobile, Alabama. I went to Livingstone College as an undergraduate, actually went there to be a Methodist preacher many years ago, but that's more detail than you want this morning. I ended up leaving Livingstone, getting my PhD in biochemistry from Emory after a period of fellowship at the National Institutes of Health. I went to back to medical school because I actually developed an awareness about the fact that diabetes was a huge issue in my family. And I didn't know that until I was a postdoc as a PhD. So I went back to medical school at Duke and then went in training, became an endocrinologist. And since that time, I've had many positions, professorships, endowed chairs. I was at one time president of the Morehouse School of Medicine in Atlanta and first African American president of the American Diabetes Association and a member of the National Academy of Medicine of the National Academies of Sciences. So I'm not going to bore you with more of a 23-page resume than that. If you want to know more, as I say, go to Dr. Google. So thank you for joining us. And let me just say that this is my maiden voyage as a presenter and as a team member of CHP. And I'm really excited to be a part of this team, to be a part of this game-changing work here in the state of Florida. And my sense is that it's going to translate into a game-changing paradigm across the states, because what's happening here through CHP is going to be a model for what can happen in other states to close these important health gaps. Now, let me just say at the outset that there's going to be a lot of meat on the bone this morning. So I hope you brought healthy appetites for knowledge. I'm not going to apologize for sharing a healthy dose of information with you today. What are my goals? Personally, to provide you with the best available evidence-based information on diabetes and its related chronic diseases. I want to make you more comfortable with the very language of diabetes and the concepts of diabetes so that in the long term, you will be more comfortable about asking questions about this disease and about giving answers to people who are going to be asking questions of you. And then I want to make you ultimately more confident, those of you who will be ambassadors of hope for the new possibilities in diabetes care for the people that we serve. So I'm going to go to my screen here and pull up the information that we will share today.
Dr. Gavin, as you're traveling there, I'll make an announcement for the chat box. Dr. Reynolds, Pastor Carol is the recipient of the most active participant on the chat box award last week.
Oh, did he? Okay.
Yes, sir. He's navigating as I'm leading a prayer breakfast. He's stationary, so Pastor Carol is navigating the chat box. And Pastor Carol, your check is on the way. Back to you, Dr. Gavin. Back to you, sir.
Thank you, Pastor Philpott. So we're going to be talking about a general theme today of diabetes, and we're going to talk about the fact that old fear now yields to new hope. After participating today, I hope that you will do a number of things. Understand what diabetes is, why we worry about it, what are the effects of this disease, and what the patterns of the complications are in the United States. And then get a better understanding of what the fear of diabetes stems from and how it has affected our approach to this disease. And then ultimately, I want you to understand the changes that have occurred, and there have been many of them, in our understanding about how this disease should be managed. And finally, to touch on how the development of new treatments and new monitoring tools have inspired new hope for better outcomes, fewer complications, and better overall health with longer lifespans and less expense in diabetes care. This is a common disease. In 2022, we had about 37 million people in this country with diabetes. It's now up over 38 million. It's a fast growing disease. By the year 2030, it's estimated that if we don't do something different, we'll have over 55 million people with diabetes. That's about 16% of the population here. And if you see from the red areas on the map, this is heavily concentrated in the southeastern parts of this country. So the things that I want you to start considering, and we're going to provide some insights on, is what is diabetes? I've talked to you already a little bit about the statistics. What are the different types? And what are the symptoms of full-blown diabetes? And how do you transmit it? How much of it is actually from genetics? And how do you get tested for it? And ultimately, how can I prevent or even control this disease? What parts of the body does it affect? And what are the major outcomes in diabetes that actually prompt fear of this disease? And finally, we're going to talk a little bit about how can I educate myself? Now, I've spent 50 years doing diabetes. So it's a big disease. It has changed a lot, but every person can actually develop a level of comfort and insight about this disease, especially if you have it. I always say to my students and my patients that, I've had to become an expert in thousands of cases of diabetes. But if you have diabetes, you only have to become an expert in one case, yours. And this kind of information is part of that. So what is it in the simplest terms? Well, this is a chronic metabolic disease, and it's characterized by the hallmark feature of high levels of sugar. We're going to say sugar sometimes, other times we'll say glucose. And this happens in a number of ways. Glucose enters your blood from the food that you eat, and then you use that glucose for fuel in your body. Your brain can only use glucose for fuel. So without intake of glucose, your brain shuts down. Our pancreas is an organ that's located near the stomach, and it makes a very important hormone, insulin, because insulin is the main hormone that helps that glucose get into your cells, muscles, liver, and fat, where it's needed to produce energy. Now, in the development of different types of diabetes, different things happen. Type 1 diabetes, your body fails to make enough insulin to satisfy the energy needs of your tissues, okay, at all. You just don't make any insulin. In type 2 diabetes, you don't make enough, and your body's cells are not sensitive to it. It just doesn't react to insulin in a normal way. Now, this is a condition called insulin resistance, and it's strongly linked to being overweight or obese or being sedentary or inactive. And so what happens in diabetes? Your body's cells are starving for energy. Over time, these high blood glucose or blood sugar levels damage virtually every organ in your body. And we'll talk more about that in a minute. Now, there are other hormones that are important, and that in the setting of diabetes, they're not normally regulated in their usual way. And that accounts for the fact that there are no organs in your body that are safe from damage in long-term uncontrolled diabetes. Now, the most significant changes that drive many of the current trends in diabetes among high-risk minorities, where this disease is very common, have little to do with changes in our genes. And this is an important point I want to make with you. Our focus should be sharply on the elements of environment and behavior that we can change. That's where the potential for making a difference really resides. So let me tell you a story, and I want you to just be patient with me on this. I could tell you two, but I'm only going to tell you one of these two stories. The first story is the case of the Pima Indians down in Arizona and Mexico. Now, these natives have been in that region of southern Arizona for since 300 BC. They were farmers because they were nested right there next to the Gila River. Because of the infusion of white settlers and the diversion of the waters, the Pima Indians lost access to the waters of the Gila River, and so they were eventually resettled onto reservation, 1859. The first recorded case of diabetes in the Pimas was in 1908. The great diabetologist from Boston, Elliot P. Joslin, subsequently documented 21 cases among the Pimas in 1937. However, by the 1950s, there was a tenfold increase. That's a tenfold increase in diabetes in less than 20 years. In 1970s, there was a prevalence, that is, the occurrence of diabetes was occurring 46%. 1 out of every 2 Pimas had diabetes. Now, in contrast, there were some Pimas who left southern Arizona and moved over to northern Mexico when the white settlers started becoming so numerous. Those Pimas who went to northern Mexico had different diets. They still had subsistence living. They farmed. They had lower BMIs. That's another term for obesity. Their physical activity levels were higher. Their fat and their carbohydrate intake were very different from the Pimas in Arizona. Now, how do you explain the fact that these were the same genetic stock, except that one group left, went to northern Mexico, had a very different lifestyle, and the ones that they left there in Arizona had a 50% incidence of diabetes? This wasn't about genes. Nothing in our genes will change over a period of 40 years or less. And this is a clear-cut case of the fact that we say the genes may load the gun, but it's the environment and your behavior that pull the trigger. So it's about our environment and behavior. Now, how can you test to see whether or not you have diabetes? This is a test, a risk test for diabetes from the American Diabetes Association. You can get this from the website that you see there. Look at the questions. This font is small, I know, but the first question it asks is, how old are you? The second question is about your gender. The third question is asked, if you're a woman, have you ever had gestational diabetes, diabetes in pregnancy? Do you have a mother or father or a brother, first-degree relative with diabetes? These questions basically touch on some of the well-known risk factors for developing type 2 diabetes. Okay? Have you ever been diagnosed with high blood pressure? Are you physically active? And what is your weight category? And there's a table over there that shows you what those categories are. And you end up with a score based on the points that you have that will tell you what your risks are for diabetes. Now, we know what the contributors are to the development of diabetes, and these are things that you should be and will become more familiar with. There are contributors that you can change. That is, things that you can modify. You're in control. Obesity and body weight, your diet and nutrition, the microbiome. That's simply a fancy word for saying the types of bacteria that occupy your gut. It turns out that they actually have a role in your risk for diabetes. And you can change those by changing how you eat, by changing certain medications. Smoking, the duration and the quality of sleep that you get. Your lifestyle, is it sedentary or is it active? And then we'll talk more about this, a concept called the social determinants of health. This includes work intensity and duration, some aspects of your socioeconomic status. The social determinants of health really encompass where you live, where you play, where you pray, the quality of your environment, whether or not you have access to fresh foods, what your educational status is, what your work status is. All of those actually play a role. And then there are some things that you can't change. You can't change your genetics or your family history. You can't change your age. Well, there's some people who think they can. They paint and they tuck and they stick stuff in. But you know what? They're still old. Okay.
Careful, doctor. Careful.
Okay, I'm sorry. I didn't mean to get personal. Okay, you can't change your epigenetics. These are the things that the environment does on a day in and day out basis on your genetics. Those are epigenetics, okay? And then there are some aspects of social determinants, including your education, your socioeconomic status, the noise levels that you're exposed to, toxin exposure. There are some things that are not in your control if you live in a place where trains are going by and making noise, where traffic is making noise, okay? The types of diabetes are important and they're extensive. We're only going to focus on one of them in today's talk. Type 1 diabetes only constitutes about 5% of all diabetes. usually diagnosed in children, not always. You can be 50, 60 years old and get type 1 diabetes. It is affected by heredity, but it does not skip a generation, okay? It doesn't do that. Sometimes there are no symptoms. It is imperative to administer insulin daily to people with type 1 because they make no insulin. Patients with this disease need insulin to survive. And these people have to have a reliable monitoring system like continuous glucose monitoring, or you will hear it called CGM. So they know where their blood sugar is at virtually all times. Type 2 diabetes is what we're going to focus on because it is the most common, by far, over 90%. Usually it occurs in adults, but there is now an increasing trend in the younger generation, especially children of color. Many children are affected, and part of that is why I worked so many years with Michelle Obama in creating the Partnership for a Healthier America organization, because we were trying to curb childhood obesity because it was giving rise to high risk for diseases like diabetes and hypertension in our children. In this disease, the body is incapable of responding to insulin in a normal way. And now, because we're seeing increased rates and rises in obesity and the failure to engage in regular physical activity and very poor nutrition habits, we're seeing this broadly in our society. We're seeing a stimulus in the risk of developing diabetes. So we have a two-pronged rallying call for preventing or even treating type 2 diabetes. One is more than you're doing now. That means more physical activity, something that you should be doing on a regular basis, and less than you're doing now. That means push back from that table earlier. Use less or smaller portion sizes and be more careful about our nutrition. Not everybody with diabetes is obese, but as you can see, it's a powerful risk factor, and 80% of people with diabetes type 2 are. We're not going to talk more about gestational diabetes today, but it's very important because this is a condition that of diabetes that occurs in pregnant women. They give birth to very large children. There can be a variety of different complications. And after the birth of that child, they are at high risk for developing full-blown regular type 2 diabetes and its associated cardiovascular disease down the line. That's why it's an important condition to monitor. And then this final condition here, prediabetes. I have this, okay? Prediabetes now affects, it's now more than 79. 86 million people are diagnosed with prediabetes. And we are people who would have above average blood glucose levels, but not high enough to be classified as either type 1 or type 2. With prediabetes, you can have long-term damage to the body, including your heart and circulatory system. And it starts with unhealthy eating habits and inadequate exercise, which is why people with prediabetes have to be physically active, watch their nutrition, and sometimes use the benefit of certain medications and keep it under control. I can say to you that mine is, so thank you. What are the symptoms? In some cases, none. You commonly see the symptoms that we hear about and talk about at the onset of type 1 diabetes. Not typically do you see these symptoms at the onset of type 2 diabetes. Type 2 diabetes comes in by stealth. It's sneaky, okay? You see high blood levels of glucose. You can see blurry vision because sugar can cloud up the tissue in your eyes. Easy fatigue, persistent thirst, sometimes frequent and painful urination because it can sometimes be associated with urinary tract infections. You can have sores that don't heal or they heal slowly, nausea, vomiting, weight loss, hunger. Full-blown type 1 and full-blown type 2 symptoms are similar, although the more explosive symptoms of this type occur in type 1 younger people. We hear a lot of questions about how do you transmit this? How does it go from one person in the family to another? Well, there are some genetic links in all forms of diabetes, okay? The most well-known genetic links are in type 1 diabetes, but there are just genetic risks that are involved and that are known in prediabetes and gestational diabetes, but it's only to give you a risk. It doesn't give you disease. Remember, the genetics may load the gun, but it's the environment and your behavior that will pull the trigger. You can develop this disease because of poor diet, inadequate exercise, known factors that prompt people to sort of fall off the rails and develop full-blown diabetes, overweight, high blood pressure, high cholesterol, a strong family history, and we'll talk more about this, certain racial and ethnic groups, African Americans, Asian Americans, Latinos, Native Americans. These are groups that have higher levels or higher prevalence of diabetes. And then if you have gestational diabetes, and then there are infections. There was a huge surge of diabetes in the COVID pandemic. That's because there are certain infections that can actually tip people over who are at risk for diabetes into full-blown disease. Now, there are tests, and there's a lot of detail here, and I'm not going to give you all this detail, but I can just tell you that fasting glucoses, this is after 6 to 8 hours of not eating or drinking anything, you can have your fasting glucose blood drawn. And if the level of fasting glucose is over 126 on 2 separate tests, that's diabetes. For prediabetes, if that level is 100 to 125, you can also diagnose diabetes by using the A1C. The A1C is something that reflects what your average blood sugar has been for the last 3 months. And it's a test that uses a special chemical analysis of the glucose that's hooked to your hemoglobin in your blood cells, okay? If the A1C level is more than 6.5% on separate tests, and remember that in some populations like African Americans, this is a test that can be falsely elevated because of differences that we have in our hemoglobin. You can also make a diagnosis using a random blood sugar off the street. If your blood sugar is 200 or greater and you have some symptoms, you're peeing a lot, you're drinking a lot of water, you're hungry without explanation, that random blood glucose is enough to make a diagnosis of diabetes. And then there's a special test called the oral glucose tolerance test that I won't go into a lot of detail about, but just know that this is something that's clearly something that is necessary for people with gestational diabetes, and it's something that doctors may use, but it has to be done under rigorously defined conditions. There's a question here from Dr. Reynolds.
Yeah, Dr. Gavin, thanks so much. You're covering things actually that as a physician of 46 years, I recall some of this stuff back when I was in medical school, right? But so many things have changed, and you're bringing a freshness to a subject matter that's so critically important for our people. And when you start talking about the A1Cs, I like how you talked about that because it's very important for people to know. The A1C is probably going to be the screening test of choice for us, for sure. And we'll start doing that within our community starting October the 1st. A1Cs tend to stay pretty stable, pretty much about the same for about 90 days or so. So there's like a 90-day window. So if you get a high A1C initially, then you may want to wait 2 or 3 months before you get your second one, unlike your blood sugars, right?
Yes.
Then something that I mentioned last week, and that was about, I call it the triad. And I know Dr. Gavin, he's already talked about triad, but I just call it, I keep it plain, keep it simple. Triad is polyuria. It means that you're peeing a lot. Polydipsia, you're drinking a lot. And polyphagia, you're eating a lot. That along with an abnormal blood sugar, you're diabetic. I rest my case, Doc. Thank you so much. Let me
Yeah, and it's important to realize that when you have that triad, by the time you get to that point, you've got now diabetes that has advanced.
Yep.
Okay, in a person with type 2 diabetes, it means that you're pretty much downstream. Okay, and it's time to get busy. Because remember, you don't develop those kinds of symptoms until your insulin levels have dropped to a significantly low level and your body is really now incapable of handling glucose in a normal way, okay? Now, I think it's important sometimes for us to stop and do a little bit of historical assessment. We throw a lot of numbers at you, and sometimes I know you're probably wondering where these numbers come from. What is it that allowed us to tell that a fasting plasma glucose of 126 is diabetes, or an A1C of 6.5% or higher is diabetes? What? How do we know? Well, I mean, I'm going to give you one example because this is important. I chaired a committee for the American Diabetes Association in 1995 that changed the way we classify diabetes, because it used to be that we didn't call people diabetic or say that they had diabetes until their fasting glucose was 140. So clearly that was way too high and we knew it. So we had to go back and revisit that. So this is what happens. Thousands and thousands of people are followed, and they have been in different groups, for example, among Egyptians, Mauritians, Pimas, American citizens. And what they do is, as you see in these panels on the right, they follow the A1C for years. They follow the fasting plasma glucose for years. They follow the 2-hour post prandial or post infusion glucose in a glucose tolerance test for years. And then they look at the frequency of different complications. In this one, we're looking at eye disease on that Y on the left axis there. You can see that the line is flat. There's no change in retinopathy at these different levels of glucose or different levels of A1C until you get to those blue arrows. And then there's a sharp rise in the incidence of those complications like eye disease. You can also do this for kidney disease and nerve disease. And it's that point where you now start seeing the sharp rise. You look at what is that value? What is that fasting glucose? What is that 2-hour glucose? What is that A1C value? And it turns out that's what determines what we use for diagnosis. Okay, so it's based in evidence from significant science. And that's, you ought to know this, okay? I just want to make sure that that point was made. How do we prevent this disease? Well, lifestyle. We talked about eating less, eating healthier, being physically active, taking your medicines as directed, no excuses, avoiding bad habits, drugs and alcohol and stress, for example, in excess, checking your feet to make sure that there's no nerve damage or interruption of blood flow. It's really important to take care of your teeth. There's a strong association between diabetes and other chronic diseases and dental health. Control your blood pressure and control your blood sugar, your blood cholesterol. Don't smoke, okay? Just don't do it. And then make sure that you're checking with your healthcare provider on some frequent basis. Most importantly, you need to know your numbers and own your numbers. You need to know the numbers that are good numbers for you. And I'm going to give you a personal bias. I had my executive physical last week, and then the technician called from the office and said, Dr. Gavin, I want to give you the results of your labs. And he said, we redrew your A1C. The A1C was 6. That's very good. He said, and all of the other parameters of interest were normal. I said, well, you know, I'm a person who likes numbers. I like to know certain of my numbers, and I like to know what my fasting glucose was. And, know what those numbers are. Don't be afraid to ask for them and to be comfortable with them. Sometimes normal or not normal is just not enough, okay? Now, there is a way that you can get free information from the National Diabetes Education Program at the NIH. It's called Your Game Plan for Preventing Type 2 Diabetes. It's a brochure that's excellent, has in it sort of the blueprint for what you can do as a toolkit to prevent type 2 diabetes. And this is one of those resources that will be very important. Controlling diabetes is one thing, but people always want to know, can you cure it? No, there's not yet a cure, but don't give up hope. We're making new discoveries all the time. More importantly, healthcare providers are now giving people treatment that can prevent the complications. You know, if you can prevent the complications and reduce the progression of this disease, you can actually live a normal life. It's almost like you don't have diabetes. So it may not be cured, but the fact of the matter is you've avoided the damage. The foundation of any approach at control or prevention begins with healthier lifestyle. That's a must, and there's a lot of help for that. Now, there is research that's being done on replacing the cells in the body that produce insulin in people who don't produce enough. And there are surgical procedures that are now available, but we're not going to go into that today. The level of control, the avoidance of complications that's possible using some of these new treatments and new tools means that people with diabetes, you'll see an abbreviation PWD, that's people with diabetes, can now live normal, healthy lifespans, free of complications. So what have we learned? Where do we stand now? This is it's a growing disease, not only globally, but in the US. We've developed some really good insights into what causes it and why it becomes more severe over time. We have good standards for diagnosing it, categorizing it. We become more comfortable in our ability to control it or actually prevent it. Is that somebody asking me something? What then explains why people have been so fearful of this disease, have had some consternation about it? There have been people who deny having diabetes. They've been ashamed and embarrassed about it, and they avoid anything that looks like treating their diabetes or monitoring their diabetes in public. Question is, why has there been such fear about this condition? Dr. Reynolds?
Dr. Gavin, I just want to make sure that our guests know that they can ask you a question, as they feel that they need to ask a question. I know we talk about this, so at any time, guys, you guys ask a question.
Yeah, also, anytime.
Also, we have Dr. Cadella. She is a pharmacy doctorate. She's also, as you know, Dr. Gavin, she's board certified in chronic, it's dealing with, I guess, chronic disease. So she's on also, and I want all the doctors that are on this this Zoom, this webinar, could you identify yourself, please? Are there any physicians and/or healthcare professionals that's on this this Zoom other than Dr. Beatrice Cadella?
Dr. Moyes is on as well.
Dr. Moyes is a very prominent physician that's in the community, both here, Dr. Gavin. I think you have met him before. He is a super guy. We've known each other for a large number of years. Let's say over 35, almost 40 years now. And he has a major practice in both Miami-Dade County. In fact, his I think it's North Miami, as well as in Orlando. He is one of our main partners with us because Dr. Gavin, Dr. Moyes has actually joined the team in its entirety now. So I was able to talk him into this stuff after giving him a little bit shot of a scotch a couple of nights ago. I got a lot of things accomplished with him. So does anyone else have any questions? No, Tina, Ms. Goldman, she's there also. She's a licensed nurse practitioner and LPN, I should say. And she's a part of our team. She's a part of what we call the CHW, that is Community Health Workers. And we have all of our community health workers are on this Zoom as well, I should say webinar, as well as a number of our CHP ambassadors. So I got to tell you, Doc, this is really good. I like your delivery of it. Maybe I can learn something from that. Don't say anything, Rudy. Okay.
Well, I realize that with some of our healthcare providers and some of our team members, that a lot of this information is I'm preaching to the choir. I thank you for your tolerance and your patience, but I'm just trying to make sure that we have a sort of a common baseline that we are all going to be related to. And when I say something that's off base or off kilter, please, I have no hesitation about being stopped and corrected or give me a different pointers. So thank you for being here. So when we think about why is there such fear about this disease. I want to dive a little deeper into that because this is something people really need to be appreciative of. One is the fact that when we look at what diabetes does, it shortens your lifespan. Okay? If you just have diabetes by itself, your lifespan is reduced by 6 years or so. If you have a heart attack on top of your diabetes, the statistics show that your lifespan is reduced by almost 13 years. If your diabetes is complicated by a stroke and a heart attack, your lifespan is decreased by about 15 years. That means that if you have life expectancy of 72 years, you see that you lose 6 of those in diabetes alone, and you see what the impact is for people with those added comorbidities. That's serious. Now, how does diabetes do all that? Where does it affect you? The answer is it can affect everywhere. It can affect your heart, your kidneys, your eyes, your nervous system, your whole body. The long-term vascular complications, including strokes, peripheral vascular disease, we call it, peripheral artery disease, hypertension, urinary tract infection, coronary disease. The most frequent health risk from diabetes is known as cardiovascular disease. High blood pressure tracks with this disease, okay? Diabetes is known to lower your good cholesterol and raise your bad cholesterol. What do you get from that? More heart disease. At least 65% of people with diabetes die from heart disease or strokes. So no wonder we have such fear of this disease. Now, the stark reality that is now well established is that diabetes overwhelmingly does not occur by itself. It travels with bad company. That's why we worry about it and have such fear of it. Type 2 diabetes, when you see type 2 diabetes, you must always look for other metabolic and cardiovascular conditions. This is something we now know. I know you're going to ask, is this just Jim Gavin talking, or is there real support for these grandiose assertions? I'm going to tell you, the evidence is quite substantial. So fortunately, it is not necessary for you to rely on simply taking this one man's word for it. What we've found, CDC tracks the diseases in this country, the prevalence of certain conditions. We have data on cardiovascular disease, its incidence, its prevalence in different populations. We have data on kidney disease. We have data on metabolic diseases like diabetes or liver disease. What we now know from CDC data is that CKD, that's for chronic kidney disease, affects more than 40% of people with type 2 diabetes. More than 50% of type 2 patients have or are at high risk for developing cardiovascular disease. And from CDC data, about a third of chronic kidney disease patients also have cardiovascular disease. They coexist, they overlap. There are these cardiovascular risk factors that are seen commonly in people with type 2 diabetes. Over 80% with high blood pressure, about 80% who are overweight or obese, and another 80% who have hyperlipidemia, bad cholesterol, high levels of triglyceride. The prevalence of at least 2 of these morbidities, or comorbidities we call them, occurs in 90% of patients who have type 2 diabetes. So it does not track alone. It doesn't travel by itself. When you see diabetes, be on the hunt for other things. So when we say that you have complications with diabetes, increased risk, there are 2 major types. The microvascular, what does that mean? It means the small blood vessels, like those in the eyes, those in the kidneys, those in the nerves. They can be affected and they give you these conditions: eye disease, kidney disease, and nerve disease. But the ones that kill you are the macrovascular, the large blood vessel complications. Those are the ones that give you strokes, coronary artery disease that give you heart attacks, and angina and heart failure. Two types of vascular complications, both of which are very common in type 2 diabetes. And this is what it looks like. I know you don't want to see this, but a normal looking eye, when your optometrist looks into your eye, should look something like that one on the left. A person with advanced eye disease from diabetes looks like that one on the right. Who wants that? You don't have to be an eye specialist to know you don't want that. Who wants a foot that looks like this? This is what happens when the nerves are damaged, and if the blood vessels get damaged, you get an ulcer, you get a requirement for an amputation. The kidney vessels on the left here, this is what they look like under the microscope. This is a traffic jam. You can't filter much stuff through this. This is what we know to be the case in people with diabetes. And so this combination of these risk factors, the more these risk factors you have at the same time, if you don't have diabetes, these little gray bars that you see, even without diabetes, you see that with the presence of multiple risk factors, you get a higher likelihood of cardiovascular disease and death. But look at what happens when you have diabetes on top of that. With all these risk factors with diabetes, now at every stage, your risk of developing cardiovascular disease or dying from cardiovascular disease is just that much higher, 2 to 3 times higher when you have diabetes with the same number of risk factors. That's why we are fearful of it, and we should be. It's a leading cause of hospitalizations. Why? Because of strokes and ischemic heart disease, angina, and coronary artery disease. This is serious. All of the systems of the body are susceptible to complications because of diabetes. We used to think that all of these complications were because of high blood sugar. Remember, that's how we knew that there was diabetes. You measured blood sugars and it was higher. People had these triads that Dr. Reynolds was talking. When people had that picture and they subsequently developed complications, everybody thought that, well, it's because of the high blood sugar. Well, there are several things going on here. One is there are multiple risk factors that interact with each other to drive cardiovascular disease. Two, the longer you have diabetes, the more likely you're going to develop cardiovascular disease. It makes sense. If you have something bad going on and it goes on for a long period of time, your risk of a bad outcome goes up gradually the longer you have that exposure. And that we have those data. That's real. But it used to be thought that, well, if only we could get this glucose normal, despite the fact that we knew a little bit about the kidney disease, obesity, lifestyle, lipids, cardiovascular. We knew a little bit about that, but our focus in controlling diabetes was on glucose. And so we went to work. I told you I've been doing this for more than 50 years, and I've been involved in virtually every one of the major studies that have tried to normalize glucose and show that you could actually prevent cardiovascular disease and death. And I'm going to show you a little data. I told you I wasn't going to apologize by giving you real information and data. This was a study that was done called the ACCORD study. Okay, that's an acronym for the Action to Control Cardiovascular Risk in Diabetes. And it took thousands of people and gave them either standard therapy in that blue line, but for diabetes at the time, this was in the early 2000s, the late 1900s, early 2000s, or it gave them intensive therapy, it gave them really intensive, multiple drugs to control their blood sugar to try to get their A1C to less than 6%. The standard therapy was trying to get the A1C to 7 to 7.9%. And then on the left, what you see is that the people with events, with cardiovascular events, they were pretty much the same. Maybe after 5 or 6 years, only slightly less with the intensive therapy, but it wasn't statistically significant. But on the right, when they looked at death from any cause, they were shocked to find out that the people on the intensive therapy actually had slightly higher death rates over time than the folks on standard therapy. This caused a shock wave in diabetes. Okay, now it wasn't statistically significant. It wasn't that strong a signal. But the fact of the matter is, it didn't show what we thought it would show. You control the glucose, and the death rates did not go down. And that's what made the FDA say, well, listen, before you ever approve another diabetes medicine, you're going to have to show that it's safe. It doesn't cause people to be at more risk. And that changed the game. Okay. But something else changed the game. Over in Denmark, there was a study called the Steno diabetes study. And what did they do? They focused on treating multiple risk factors, not just glucose. They treated everything. They treated the blood pressure. They treated the lipids. They did all of those things in addition to the blood pressure. Stop people from smoking. I mean, blood sugar. Stop people from smoking. And you know what they found? They found that intensified treatment that targeted everything was associated with an almost 8-year longer lifespan over 21 years of following those people who were participants in that study. So just targeting the glucose was not enough. You needed to target all of the risk factors. So what we've learned to help us move from fear to hope is that we want to get out of the past, but we don't want to leave anybody behind. We want to take charge of diabetes, but this is a dynamic and a collaborative process that requires that we understand that it behaves somewhat differently across different populations and different groups. It's no longer just about getting the blood sugar to normal or near normal ranges. That's important. Don't get me wrong. You have to get the blood sugar in control. It's a very powerful and important screening test, but it's about much more than that. Following the blood sugar simply tells you that you ought to be watching those other things more closely too when the blood sugar is not at goal. One feature of diabetes that has not changed is that it must be taken seriously. And what has happened now is that we realize that diabetes is a cardiometabolic disease, that it is a disease that has implications for the health of the heart, it has implications for the health of the kidneys, and it's not evenly distributed. So cardiovascular disease, congestive heart failure, chronic kidney disease are all part and parcel of the diabetes package. So now we have to look at things beyond glucose. We have to look at blood pressure. We have to look at lipids. We have to look at mental health. And in the process, we ought to be checking vision. We ought to be checking feet. We ought to be looking at diet. Okay? Now, I said that diabetes doesn't behave the same across all groups. In fact, there are significant disparities. One of the reasons why CHP is doing what it does and why it's so important for it to be doing what it does is what Dr. Martin Luther King Jr. said years ago. He said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. What does he mean by that? Well, first, when you look at the rates of this disease, this is from CDC. If you look at white non-Hispanics on the far right, women and men, they have the lowest rates of diabetes. But now look at the other groups. The highest rates are at the other extreme, American Indians and Alaska Natives. But right there in the middle, Blacks, non-Hispanic, and Hispanics. Higher rates by far than the majority population in this country. And when you look at how this disease behaves, 55% of Americans with diabetes are either Black, Native American, Hispanic, or Asian. People of color with type 1 diabetes are less likely to take advantage of all of this new technology that we have. Compared to white Americans, Black Americans are 3 times less likely to use an insulin pump than the modern way of delivering insulin, other than, you know, syringes and bottles and needles. Blacks and Hispanics are twice less likely to use a continuous glucose monitor. And the data don't stop there. We have higher A1Cs in Blacks versus whites due to our infrequent use of technology. We have higher rates of complications. We're twice as likely to die from diabetes-related complications and almost 4 times more likely to have end-stage kidney disease. So it behaves differently, and we have to deal with it differently in communities of color. This is an urgent priority for us. We have to reduce the disproportionate impact, loss of vitality, prosperity, and longevity that result from this imbalance. We got to close the gap. That's what we're talking about here. It starts in history.
Dr. Gavin, I'm on my phone, so please forgive me. Can't figure out how to raise my hand.
That's okay. Go ahead. It's all right to interrupt. Anybody else
Yes,
can.
sir. Can you go back? My mom is on this call, and she can correct me if I'm wrong. She takes what you just characterized as traditional intake versus the newer technological ways of getting insulin. Can you kind of expound on that a little bit? Because
Yeah, and this is
totally
not to say, yeah, thank you for the question, Pastor Philpott, because I want people to understand that the key thing here is that there are multiple ways of doing things like insulin delivery. Okay, you can use a traditional approach, that is with a syringe and a needle and a bottle of insulin. We don't see that very often anymore because now we have insulin pens, and I'm actually going to be talking about that a little bit later towards the end of this talk. You can have insulin pens that are pre-filled. The insulin is already in it. You can dial the dose that you need and give it as an injection. Sometimes you don't even see the needle. Okay, so those are now different approaches that can be taken. Usually, when you move from one type of insulin delivery to a more advanced type of insulin delivery, it's because you get more efficiency and more accuracy with the more advanced type. And that's a decision that you make on a person-to-person basis. A person could be using traditional methods and still do fine, but the control that you achieve tells the tale, okay? If you're not getting to the goal that you've set, one of the questions that you may need to ask is, do I need to use a different system or different of delivery of insulin in this case, or a different type of medication therapy structure altogether? So this is not to say one thing is necessarily better than something else. It's just that when you have a need in order to improve what you're doing, there are now more modern systems. Pumps are preloaded, they are programmed, they can be on automatic settings. You put the little catheter in, it stays in under the skin, and you can go. Not everybody needs one, okay? We're developing for type 2 patients, we're developing some things called patch pumps. I'm not going to talk a whole lot about those today, but in future talks, I'm going to be talking about new technologies for insulin delivery and other injectable therapies. Okay? So your mother may want to talk to her provider about a different approach if the one that she's using now isn't getting them to the agreed upon goals. Is that?
Thank you, sir.
Okay.
Yes, sir. Yes, sir.
So just quickly, when
Dr. Gavin,
Go
sorry,
ahead.
I didn't mean to interrupt, but I have a question.
Yes.
Can you use insulin pumps along with oral medications, for example, in a patient that have type 2 diabetes?
Yes, you can. And in fact, in type 2 diabetes, it is not uncommon at all to use multiple types of therapy. And remember, the way you deliver that therapy is simply a consequence of what you've determined to be best suited for that patient. But yes, you can have oral agents plus injectable therapies that could include insulin or other types of injectable medicines. Right now, the GLP-1s the types of things that are very popular drugs now, the Ozempics and the Trulicities and the Mounjaros. All of these are things that can be used in type 2 patients along with other oral forms of therapy. And in fact, that's most commonly how we see them done. Okay, so
Gavin,
yes,
question for you again. Getting back to, let's say I'm a new patient, right? I have some concerns.
yeah,
I go to my primary care doc. I happen to be like 65 years old plus, right? And I'm going to a primary care doc. As an internist, I guess I can understand that. But my question is this: what should the average person go into their physician's office with, even as an inquiry about being checked up for diabetes? What's going to be the plans for me for them to determine if I have diabetes, and then what's going to be the actual program that they will set up for me? I'm asking a question because I know that a lot of our patients will see doctors that they tend to blow them off a little bit.
yeah.
They don't focus in on what they're saying. And oftentimes we people of color, we don't even ask questions because we feel that, I don't know, we just don't want to answer doctor questions, right? So,
Okay, so one of the things,
go ahead.
yeah, one of the things that I said at the outset is that one of my goals was to make you more comfortable with the language and the concepts of diabetes, and to make you more comfortable about asking questions and about giving answers related to diabetes. Okay, and sure enough, Dr. Reynolds, a little bit later in the talk, I'm going to talk about how do you get yourself to the point where you're asking the questions and you're comfortable asking the questions. What types of questions should you ask? So stick with me a little bit. Let me get to that. Okay. But what I wanted to do, just in terms of this background, is show that this difference in the way diabetes behaves in minority populations, we've known about this for a long time, and it has nothing to do so much with genes. Okay, this was something that very telling right here. This is a comparison that was done between physicians who had graduated from Meharry, all black medical school at that time, and Johns Hopkins. This was all white. They took a group of graduates and followed them for 23 to 25 years. Okay, now these were doctors who had gone out into practice. In that 25 years of follow-up, the black doctors were more likely to have a higher risk of cardiovascular disease, an earlier onset of disease, higher incidence rates of diabetes and hypertension, twice as high, higher incidence of coronary artery disease, and a case fatality rate of 52% versus 9%. That is, their death rates were 5 times higher. Now, I want you to note this, that the black physicians were free from poverty. They lived largely, however, in black communities. They received health care from persons like themselves, and they had lifestyles characterized at that time by poor dietary habits. Too many of them smoked, and they had inadequate regular physical activity. This is a statement about the social determinants of health, okay? And the genetics might be there, but it's how you behave and your environment that pulled the trigger. So new strategies, and often different strategies, are required to improve outcomes in that are disproportionately affected. That's why we're talking like this, and we're going to get to questions about how you educate yourself. But make no mistake about it, there have been some successful things that have been done that can reduce these diabetes-related health disparities. We're not the first. A lot of people have been doing this, and we're trying to pull all of these experiences together to have broader impact. One of the things that has been done by a group, one of my mentees was heading up this group, Sharita Golden. They worked with healthcare organizations. They looked at disease management. They looked at putting together registries so that they knew who had diabetes, how many people were affected. They looked at practice guidelines. One of the things that is clear, Dr. Reynolds, is that if your providers are not using current standards of care, evidence-based practice guidelines, it means that you're not getting the quality of care that you deserve and that you are absolutely required to get in order to get good outcomes. Okay, you have to have information technology, health records that can track and monitor the progress that patients are making. And then you have to have a care management plan. All of those things need to be in place. When they are in place, as this group demonstrated, they saw improved diabetes outcomes. But look at the other things at the community level. They used culturally tailored patient education and empowerment. That is to say, they met people where they were. They used community health workers, what we consider, what we have in CHP, ambassadors, who were trusted voices. These were the people that could talk comfortably and talk meaningfully to people about their conditions and the barriers to better outcomes, and really help to reduce these disparities. Okay, so this has been done. And what has come out of this is the development of guidelines, right? Now, this is important because when you look at different groups who have different complications, different comorbidities, and you look at the differential effects of the various treatments in specific clinical settings, you can now develop treatment guidelines that can guide your therapy. That's what this GDMP, that stands for Guidelines Directed Medical Therapy. No matter who the provider is or who the patient is at the time. This is a development that has helped to reduce the fear in certain healthcare providers who've not been comfortable at treating diabetes. There was a time when cardiologists wouldn't treat diabetes. They want to send them to somebody. That was a time when nephrologists, kidney doctors didn't want to treat diabetes. They want to send them to somebody. And then there are a lot of primary care providers who basically never really mastered the therapy of diabetes. And then on top of that, there was implicit bias where they treated one group differently, less seriously than another. All of these are now targets of our attention, okay? Now, what does that mean? By using this GDMP, we're now targeting risk factors because these risk factors are what's causing people to die, to develop heart disease and heart failure and kidney disease. You now have to have strategies that focus on reducing the risk of these outcomes, no matter what your A1C is. A1C is going to be important, but it is not the end all and be all. It simply gives you a marker for where a person is in their disease. And the GDMP is based on evidence, okay? You can reduce the small vessel, the eye disease, the kidney disease, but you may not reduce the big vessel disease. And that has led to us reorganizing the way we think about diabetes management. Our goals have shifted from sugar-related goals and glucose-related goals to heart disease-related goals and kidney disease-related goals. But one size doesn't fit all. When you see one case of diabetes, you've seen one case of diabetes. We have to make sure that, especially when it comes to high-risk minorities, we treat people one case at a time, taking into consideration what their individual needs are. Do they have cardiovascular disease? Do they have heart failure? Do they have kidney disease? You don't know unless you look. What is their level of obesity? What is their lifestyle? What is their quality? These are the kinds of things that people need to go into their practitioners prepared to talk about. If they aren't asked questions about that, you already know that you're not receiving the quality of care that you need to have. Minority groups are far more likely to present with one or more of these cardiovascular comorbidities, okay? And you need to know that somebody is looking for them to see if you have them, and if so, at what stage are these conditions. Again, is it just me talking, or is there evidence to support this? Well, I'm going to show you something now that I don't want you to get scared, okay? What this is what the American Diabetes Association provides to providers as a blueprint for how you should be treating people who come to you with diabetes. Okay? What you see in that top blue line, healthy lifestyle behaviors, diabetes self-management education and support, and the social determinants of health. The American Diabetes has incorporated all of that into the first line of what you need to be considering when you're treating somebody with type 2 diabetes. Now, I'm going to break this down into parts because when it comes to specific issues, you want to know, well, what should the health providers be doing? If you have ASCVD, that's simply an abbreviation for atherosclerotic cardiovascular disease. That's defined differently depending on which one of these cardiovascular studies that was done. What you have to do if a person has it, and you know if they've had a heart attack or transient ischemic attack or unstable angina, if they've had an amputation or coronary artery disease, if they have that, what this blueprint says is that person, in addition to anything else that you have them on, they should be on a GLP-1 that has proven cardiovascular benefit, or an SGLT2, which is a different type of medicine, proven cardiovascular benefit. That's what the guidelines say, okay? And you're doing this to get their A1Cs to a goal. But remember, these now are medicines that do more than just lower your blood sugar. These are medicines now, this is part of the new hope in diabetes. These are medicines now that can have effects on other organs beyond lowering blood sugar. They have protective effects on your heart, protective effects on your kidneys, okay? So if you have a high risk, you need to establish what that risk is. Hypertension, smoking, dyslipidemia, they're spilling proteins in their urine. You need to know that. And you can only know that by testing. If you have heart failure, doesn't matter what, there are different types of heart failure. We're not going to go into that. There are different types of heart failure. The guidelines say if you have heart failure, no matter what type it is, you need to be on one of these new medications, one of these SGLT2 drugs, because the data show that there is enormous benefit in reducing the progression of that heart failure and reducing hospitalizations from that heart failure and reducing deaths.
Dr. Gavin,
Yes.
can you go back to slide again regarding the SGLT2s? There's a lot of people that are on the webinar that are not physicians and or clinicians. You may want to explain what are those medications. If not, we have Dr. Beatrice. She certainly can answer those too, but because to me, I would be getting a little bit disconnected in that there's a lot of things being thrown out at me, and I'm the general public. I don't know what type of GLT or SGLT2 is, so
Yeah,
could you kind of explain that a little bit?
The GLP-1s, well, you have to realize that when most of the time when we talk about these things, the FDA prevents you from using brand names, but we're talking now to a general audience and we're all family here.
Right.
We can use brand names. So the GLP-1s are injectable drugs. There's only one oral form of GLP-1s. They're drugs like Ozempic, Trulicity, Mounjaro. Okay, those are the types of drugs that are in the GLP-1 family. Byetta. SGLT2 inhibitors are oral drugs. They're pills. Okay, they are the Jardiance, the Farxiga, Dr. Padilla. You can weigh in on all of the different ones that are commercial.
Absolutely. So if I have a second, so glucagon-like receptor agonists like Trulicity, Ozempic, and Victoza, out of all the class, those three that I mentioned are the ones that have proven cardiovascular benefit from protecting you from having a heart attack or a stroke. These agents are very powerful at weight loss. Ozempic is the one that is associated with the most weight loss compared to Trulicity and Victoza. And then Monjaro has like a dual effect. It is a incretin-like peptide, and also a glucagon-like receptor agonist. All of these medications act in the same biochemical pathway. They basically mimic a hormone that we have normally in our bodies that we produce naturally, especially we release it after we eat. And it tells our brain, hey, I'm eating, let's prepare for digestion. And it also tells your brain, hey, I'm eating, I don't need to eat a lot, I don't need to overeat a lot. Let's stop eating. I have like early satiety, right? You stop eating earlier than you technically would with this medication. And so it kind of slows down too how quickly your stomach moves. So the food will stay in your body for a longer period of time. You will feel fuller for a longer period of time. You won't have those cravings in between your meals too. And so that is how it results in significant weight loss. Monjaro, because it has that dual effect, it kind of has a stronger impact, a stronger satiety effect. It has a stronger impact on those, reducing those cravings. So you have even a more weight loss associated with Monjaro compared to even Ozempic. And so these agents basically make you eat less. You kind of are going to be eating like about 1/3 of what you usually were eating before. And it also is going to help your body kind of prepare to digest that food, and move all those sugars from the blood into your cells so that the sugars can be used for energy. So that means that you're going to be producing more insulin from that pancreas that's a little bit lazy. When you have diabetes, it kind of helps the pancreas kind of work optimally better. And then it's going to make you more sensitive to the insulin. And as you lose weight, you start having less insulin resistance too. So these agents have been in the market for a while. Ozempic has been in the market, I think, since 2015. So there's extensive literature, extensive studies and data, years and years of data that have proven in large trials with thousands of people that this medication protects you from having a heart attack or a stroke. We're waiting on trial results from Monjaro. At this time, Monjaro does not have any cardiorenal, cardiovascular, and kidney benefits. But in the next couple of years, it probably is going to have or show that it has similar benefits to Ozempic and Trulicity. I think with Monjaro, you can have up to a 20% weight loss, total body weight loss, compared to Ozempic, where you can experience about a 10 to 15% weight loss. So that's significant.
Yeah.
That is very significant. And now Wegovy is a newer agent for people that don't have diabetes or have pre-diabetes. Wegovy is basically semaglutide. It's basically the same thing as Ozempic. It's just sold on a different pen with a different name, but it's the same chemical structure. And Wegovy is being studied, has been studied in people that do not have diabetes. They have obesity, and they can have some comorbidities or complications of obesity, such as pre-diabetes or high blood pressure or high cholesterol. If you have those comorbidities and you're overweight or obese, Wegovy has been proven to also impact your weight loss. You have about like a 15% weight loss too. And also has been proven to protect you from having a heart attack or a stroke, even without having diabetes. So we know that obesity is a major cardiovascular risk factor for having a heart attack or a stroke alone, not even with diabetes. When you add other chronic conditions to obesity, of course, it even adds more cardiovascular risk factors for you having a heart attack or a stroke.
Thank you very much, Dr. Padilla. And one of the bottom lines here is that these are new classes of medicines. The first of these, the GLP-1s, was introduced back in 2005, 2006. So they haven't been around forever. Okay, the more powerful ones have only been around for the last decade or so. So they are drugs that can not only lower your blood sugar, as you just heard, but they also protect your other organs. This is something that we did not have in the diabetes field prior to the introduction of these medications. So it is a game changer. And that has been what has inspired hope. And heart failure, which is such a bad outcome, heart failure occurs more commonly than heart attacks in people with diabetes. And when you lose the ability of your heart to pump and to generate adequate blood flow, you got a real problem. And these are now drugs that actually improve the function of your heart. Chronic kidney disease. We already said that the number of people who have chronic kidney disease as a result of their diabetes, this is especially true in African Americans. Okay, we have a huge proportion of the kidney disease in our population. We now have drugs in the form of these SGLT2s, these Jardiance, Forxiga, et cetera, types of drugs in Invokana that can actually have a significant improvement in kidney function, stabilize kidney function, prolong defer the time before a person needs to go on dialysis. That's powerful. And chronic kidney disease, as I show here, this is disproportionately higher in African Americans. That's why we have to focus on the availability of these kinds of agents and make sure that you ask why you're not on them if you know you have kidney disease, okay? It doesn't matter what your sex is. It doesn't matter what your age is. What you see is that there is more chronic kidney disease in African Americans than in other populations.
Dr. Gavin, that goes across the board for every doggone chronic disease that we have. There's a lot more incidence of African Americans dying prematurely as compared to our Anglo counterparts because we're not getting, I don't know, maybe the appropriate therapy, the treatments, maybe so we're not listening very well. But you mentioned one thing, congestive heart failure, guys. I talked about this last week in my webinar. And the moment you've been diagnosed with congestive heart failure, your prognosis is less than 5 years or less. From the diagnosis of congestive heart failure, that's why it's so important, so critically important for us to continue to put the word out that you got to make sure that you keep your heart in good shape, kidneys in good shape, and guess what? It's going to be the blood pressure and the diabetes going to take us out. No question. I'm done.
Yeah, when you have a diagnosis of heart failure, your prognosis, that is your life expectancy, is just like it is for certain cancers. It's just that bad.
Yep.
Okay. And then when we talk about kidney disease, which goes hand in glove with heart failure, okay, African Americans are 12% of the population, but we are a third of the end-stage kidney disease people. Okay, that's a huge disproportion. We're less likely to get a transplant. We're less likely to be referred for a transplant or be put on the waiting list. The waiting time that we have for a transplant is twice as long. So in other words, that's what we talk about when we talk about disparities. And those are the kinds of things that we have to be vigilant about. How do you know if you have kidney disease? Okay, you need to make sure that your healthcare provider is measuring the right things. Yep. And you say, well, how do I know about that? Well, you ask.
That's right.
And that's why I say you shouldn't own your numbers. If you don't know whether or not you're excreting protein in your urine, it means that somebody has not done an adequate test of you. Mm-hmm. If you have not had this is the language that we have to get comfortable with. Your estimated glomerular filtration rate, that's what that EGFR is. It just simply talks about what the efficiency is of your kidneys in cleaning up your blood. Yep. You need to know both things. Are your kidneys cleaning your blood efficiently? That's the EGFR. And is your kidney structurally intact? That's what the protein tells you, that there's no damage of the blood vessels in your kidney. And those are tests that need to be done. They should be done routinely, especially in people with diabetes.
Dr. Gavin, I'm one to ask a very intentional, admittedly ignorant question. So
none of these questions are ignorant. I'm dumping a lot of information on you, and I'm doing it intentionally.
Yes, sir. So, well, you and Dr. Reynolds have kind of hinted towards knowing what to ask, how to ask. Mm-hmm. And I put in the chat earlier that I've been diagnosed as a pre-diabetic, but I want you to kind of follow this, and I think this happens to many people who look like me. Dr. Mary Whitehurst is over our health and wellness ministry. She's on the call. We had a community doctor come to church 5-6 years ago, stuck a pin in me, and the result was pre-diabetic. Now I have, Dr. Cadelia mentioned, she responded that I should have a conversation with my primary care doctor. So I get my blood work once, twice a year. No primary care doctor has ever told me that I'm pre-diabetic. What questions do I ask when you mention, Dr. Gavin, when they say I'm normal?
Okay.
Do I just ignorantly say which one of these things apply to my kidney? Which one of these things tell me if I'm diabetic?
Yeah.
How do we practically ask those questions when they're
Right.
telling us we're normal?
Excellent,
question.
excellent question.
Good question.
And that's exactly where we were trying to go with all of this. So first and foremost, the reason that I'm giving you all this background stuff, Pastor Philpott, is because you need to know what is associated with what. You know that diabetes as a diagnosis is associated with one thing, blood sugar level. Okay? That's how we make the diagnosis. Now, it's associated with a whole lot of other things when it comes to the complications. But for diagnosing it, to know whether you have it or don't have it, it's blood sugar level. Now, so when somebody tells you that you have a normal laboratory test, you want to know what is your glucose level. I just told you that if your glucose level, after you've been fasting for 6 hours or so, if your glucose level is above 126, you should be concerned about that for diabetes. If your glucose level is above 100 after you've been fasting for 6 hours or so, that's pre-diabetes. A1C. Now, people won't start measuring your A1C unless you have known pre-diabetes or diabetes. But if it's more than 5.7%, that's at least pre-diabetes. But if it's more than 6.5%, it's diabetes. So you need to know the numbers. And that's why I want to make sure people are familiar with the fact that numbers tell the story. When somebody tells you normal, quick story. When my wife and I got our annual executive physicals at the same time last week, the young provider that went in to see my wife is PhD, but you know, she thinks sometimes like something else. I guess she'd been married to me for so long. But anyway, he measured her blood pressure. Her first blood pressure reading was 162/82. And he said to her, that's normal. And my wife said, it certainly is not. Because it is not.
Yeah.
That's because she understands what normal ought to be. Okay. And now the fact of the matter is that there's such a thing called what white coat hypertension, where your first reading in your blood pressure in a clinical visit is sometimes elevated, because the second one that he took later on in the visit was 140/76. Okay. Well, we need to be familiar with those numbers, and you're right, you need to ask, what is the actual number? And then the more we have these kinds of exchanges, the more you will become familiar with what quote normal really means. But when normal can be associated with a number, ask for the number. Dr. Moishe, I think, has his hand up.
Yes, thank you for a great presentation. It's interesting that just on this webinar alone, you, Dr. Gavin, Dr. Philpott, myself, we are pre-diabetic. So this is interesting.
Yeah.
You mentioned that to test like the GFR, some of the labs, periodically. Would you say every 3 months, every 6 months? How often do you think that we should check these labs?
Yeah. If a person has no known abnormalities, then you can do routine testing, especially if you're in a high-risk group like we are. You can do every 6 months, even every year. But if a person is known to have an abnormality, for example, those of us with prediabetes, you know what, we need to have those assessments done no less frequently than every 6 months. Okay, because you can have progression. So part of how frequently it's done is a function of whether or not there is something already happening and whether or not it's treated or not. If it's under treatment, you need to do tests often enough to see whether your treatment is working. So in general, that's why people with known conditions will generally fall in that category of, 3 months assessments to be safe. Dr. Reynolds pointed out, an A1C basically will not be expected to change for a couple of 2 to 3 months.
Correct.
So there's no point in doing an A1C every month. It's not going to change all that much. So those are the kinds of guidelines that I think are probably the most reasonable and practical that will give us the information that we need to keep patients out of trouble. Does that make sense?
Yes, thank you.
Oh, okay, Dr. Gavin, I want to recognize a person that is on the Zoom. She's coming to us from Mass General. She is getting her master's in nursing. I'm talking her into going further into the medical profession as an MD. Her name is Jaden Jackson. So Jaden, could you say hi to everyone? He's probably frightened. Jaden, are you there?
No, if she's coming up from Harvard, she's not frightened.
Oh, well.
She might be muted.
Yeah.
All right. I'm going to try to get to the end because there are a couple of things that I want to make sure to include before we turn on. I'm going to skip this next one here and talk about what is a comprehensive approach to kidney disease. And this is just basically what the pyramid ought to look like. Look, if you have kidney disease, you see what the foundation is? Diet and exercise, don't smoke, and watch your weight. And then that second level, for drugs, you can still be on metformin. You just have to have a level of metformin. This is kidney disease with diabetes. You just have to have a certain level of metformin based on what your kidney function is now. And look how prominent that SGLT2 inhibitor that we talked about is. And then other drugs that are known to be effective for kidney disease. And then in that top layer are the things that would help you get to the optimal goals in people with diabetes and kidney disease. And look at what's at the very top: blood pressure control. All of these things are interconnected. Okay, you cannot benefit one without having a beneficial effect on it. You can't protect your kidneys if you don't control your blood pressure. You can't protect your kidneys if you don't protect or control your blood sugar. Okay, and I've already told you that the heart failure is more common than heart attacks. Myocardial infarction is the other word for heart attacks in patients, no matter how long you've had diabetes. Look at those red squares. The red squares outrun the green squares, which are heart attacks at every level of diabetes duration.
Yep.
And we've already told you that if you have heart failure, you got bad news. Okay. And then I'll skip to the final part of what I want to say, and that is that when we have these chronic diseases, and we're going to be talking more about these, you really have to have a comprehensive care plan. There is no one provider that's going to be able to take care of these chronic diseases, which have so many moving parts, okay? And this is important because if you think about the growing management theme for chronic diseases like diabetes, what's ideal? Ideal means that you need a team. Now, not everybody needs to be in the same place, but you at least need to have access to these team members. Primary care provider, it's got to be sort of like the quarterback. Patient is a captain, okay? But look at who else is necessary in order for us to make sure that the patients have all of the things that they need in terms of information, the kind of care for the issues that can come up: nurses, endocrinologists, mental health professionals, dietitians, advocates, pharmacists, diabetes care and education specialists, kidney specialists. We need the access to a team in order to have the outcomes that we desire. How do I know that? Okay, is that just me talking again, or is there any evidence? Well, I'm going to give you evidence, because this was a study that was done where a multidisciplinary team, a team approach was used to take care of patients in this who had diabetes and had high risk of cardiovascular disease. Those people who had traditional care that do it like we do it now, you know, basically one person trying to take care of most things.
Yep.
They had the cardiovascular disease rates in the red bar.
Yep.
People who had that team approach in that gray bar. 52% lower incidence rate of cardiovascular disease. People who went to what's called a diabetes kidney disease clinic, DKD, where they had a team that had all of these people, endocrinologist, nephrologist, dietitian, advanced practice nurse, APN, clinical pharmacist, social work, team approach. What happened? Well, the bottom line is in red. A team approach reduced the risk of progression to stage 5, that's dialysis, kidney disease, by 45%. They had A1Cs that went down, their blood pressures went down, and their protein excretion in their urine were significantly reduced. Team approach.
Yep.
It works. This is why we really have to do what we're doing. Unlock a world of care and support. Now, we have an organization that I don't have time to tell you about, Healing Our Village in Georgia, but we do some of the same things that CHP is doing. I think CHP is doing more and more broadly right now, but we're doing some things that I think would be of interest to CHP and that we talk about. We have a mobile van, okay? And our mobile van actually goes out to rural areas to take healthcare and health and medical education. Okay, I'm thinking, and we'll talk more about this in coming months and whatever, about whether or not this kind of thing can be an element of services provided by CHP in some of the more remote areas of Florida.
Can I say something, Dr. Gavin?
Go ahead.
Dr. Moyes, can you speak up about our mobile unit that we have and more than one?
Yes, thank you. Yeah, we actually have 2 mobile units that is set up to do just that and to actually do examination as well. So we have 2 mobile units ready, and CHP has been using them already. So on this side, we're good.
Fantastic.
How big are those, Rudy? How big are those?
Oh, they're huge. They used to be like former mobile homes that we
Yeah,
have
we have 2
converted.
examining rooms in ours.
Yeah. Same here.
Fantastic. Well, we'll talk more about
You
that.
copied. You copied on me, Dr. Gavin. You copied on me, man.
This is good.
Thank you for being the model.
This is good.
Hey, you guys almost sound like Mr. Trump. How big is your crowd size? Keep going.
It's smaller.
Well, at least nobody's leaving, so thank you.
Yeah, right. Yeah, we're good.
Okay. So the final thing that I'm going to point out is new tools. You know, once upon a time, it wasn't too long ago that people used to say if you had diabetes, you had to have a glucose meter. Prick your finger, get a drop of blood, and measure that blood sugar. That you couldn't do without it because you didn't know where you were without that. Well, this field has moved so fast because now we have continuous glucose monitors where you put a sensor on your arm, an indwelling plastic catheter, not a needle, it's a little plastic catheter that picks up the blood glucose in the fluids in your body and measures that minute to minute and sends that information to either your smartphone or to a sensor. And so you know what your blood sugar is. You reduce levels of high blood sugar, you reduce levels of low blood sugar or hypoglycemia. It gives you what's called an ambulatory glucose profile. That just tells you what your blood sugar looks like minute to minute. Okay, and it does that for up to 14, 15 days. And you can get printouts of what that looks like on a daily basis. So what is this telling you? It's telling you that little gray zone, that's what you're trying to do. You're trying to get your blood sugars in that gray zone. You see when they are misses, in yellow, it's too high. Red's too low. Whenever you get red, that's the first thing you should focus on.
You're right, right.
That's low blood sugar is dangerous. Okay. But see, now you see what time of day, which day you're having a problem, and you can go back and look at the records to see what was I doing? What caused my blood sugar to either dip that low or to go this high? This is now something that can help with problem identification and problem solving. Here's a caveat. Minorities are significantly underutilizing this kind of technology. Okay? This is one of the gaps that we're trying to fill. Okay?
Can I make a comment, Dr. Gavin?
Yes.
Right now, from what you just showed, I got something that is better than that, Doc. You're talking about technology constantly evolving. I'm trying to get a grant from the state of Florida, maybe the CDC even, certainly donors, to give us these watches. These watches, guess what, Doc? There's no pricking. You get your blood sugar real time. It can be transmitted to our platform for, shall we say, telemedicine. You get your blood pressure, O2 sats, and a 3-lead EKG.
Yeah.
$59, and it's so doggone accurate. It's like right around 99% accuracy.
Yeah, and we, you know what, we need more of that technology, but what we need in addition is we need to do studies, and I'm not trying to sound like a nerd here, but we need to do studies in our population to show that one, that accuracy is repeatable and sustainable, so that when we speak about it, we're telling people what you can expect to get and what the impact is going to be.
100%.
Okay, so we've had a long history of getting over the fear of one of the worst things that people used to think about, diabetes. If you live long enough with diabetes, type 2 diabetes is our focus today, you will probably most likely require insulin at some point. And boy, people have always been scared of the needle. Well, you know, it turns out that's been probably an undeserved fear, but we have nevertheless had to deal with that. So a lot of progress has been made. A lot of progress has been made in terms of needle technology. Now needles are so small you can hardly see them. Okay, and more likely than not, we're going to be moving to more and more of these kinds of devices. I talked, Dr. Philpott, talking about injections, traditional injection approaches. This is a more traditional injection approach now than the syringe and bottle. This is a pre-filled insulin pen. There's various ones that are available that you can dial up the dose, press a button, and you got your insulin injection, okay? And we have pumps that can be put on the skin. They're called patch pumps. There are a whole family of these things, okay? And then there are pumps that have catheters attached to them as well. So there's a whole, but the future talk is, we'll go in depth on this, but these are different insulin delivery devices that you need to be aware of, that they're out there, okay? And they are improvements. So we have now finally begun to use a lot more of what we know. And there are programs that help us, especially patients, to know more about managing diabetes, because our goal is self-management. That's the golden summit of diabetes care. The National Diabetes Education Program, which is a joint program of the NIH and the CDC, makes available this kind of information, okay? So much has happened that has inspired this new hope. We know how common this is, but we also know a lot more about how to individualize, follow up, and treat different kinds of disease. These new drugs that you've heard talked about, Dr. Khadija talked about, the GLP-1s, for example. We talked about the SGLT2s that have multiple benefits across multiple organ systems, not just improve your blood sugar control, but help your kidneys, help your heart, you know, protect other organ systems. We can monitor what your control is more accurately. easier, with less pain, with more sustainability. Insulin therapies, much more simplified, much more user-friendly, and more automated. And diabetes education is more accessible, it's more understandable, and is more likely to result in what we would call a fully empowered patient. Somebody that can go in, Pastor Philpott, and ask the questions that need to be asked and hold accountable the healthcare providers for giving you the answers that you deserve. We're getting a lot better at team care.
Yes.
So you ask, how can I educate myself better on diabetes? Well, there are some internet sites. There are brochures. There are books. Notice this is a shameless plug. I even put one of mine in there, but I guess there's a little dot of the Trump in me. But anyway, you can read statistics from credible sources, join a support group, and look, enroll in CHP educational initiatives and screenings. There are any number of ways that you can better educate yourself on diabetes. Why is it important? Because this is the only way that you're going to generate an informed, empowered patient. When you get an informed, empowered patient, that patient has already become an ambassador.
Yep.
Because this is the patient that has motivation, information, skills, and confidence to effectively make decisions about health, their own health, and managing it. And we help promote this status to empowered by promoting active self-management from the beginning. We enhance psychological care, beginning with some of the early interventions. Get rid of the fear, get rid of the hesitance. Enhancing communication between people with diabetes, those PWDs that we talked about, and healthcare providers at the start of the treatment program is a must. And with that, I simply say, remember, take control of your life. Don't let diabetes control you. You control it, and it is entirely possible to do so. The final thing that I would say is this. I know I've dumped a lot of information on you. I've done it purposely because I want to establish a framework. I want to give you some idea about what the breadth and scope and how dynamic this space is called diabetes and what its relationship is to some of the other chronic diseases that you will hear talked about. But in the future, we'll have more in-depth discussions on specific topics, okay? So that we can get to some of the discrete and unique questions you have. We'll talk about prevention. There's a whole world of prevention that's out there in diabetes. What are some of the latest treatments in obesity? Dr. Khadija alluded to some of this when she talked about the Mounjaro, the GLP-1 that gives you weight loss that's already in the same range as bariatric surgery. Okay. We'll talk more about what you eat, nutrition and diabetes, about CGM, which would this continuous glucose monitoring, which are the seat belts of the diabetes journey. It's the only way you're going to be able to get to the goals that you set. We'll talk about some of the newest developments in insulin therapy in more depth, including the new insulins. Did you know that there's now a once weekly insulin that's out there? So there's a lot that's happening that we will need to talk, but we can't do it in one 90-minute session.
Right.
We'll talk about new updates on pumps and injectable therapies in diabetes, and there are just a whole world of those. Diabetes in children deserves a discussion on its own. Diabetes in minorities. I've only brushed the surface of talking about diabetes in minorities and inequities here today. And then clinical research studies. Companies are doing clinical research studies, trying to make sure that new tools and new drugs that they're developing can be effective, can be used safely in different populations. And in order to do that, they have to be engaged with communities. But whenever there are clinical research studies done in these communities, the quality of healthcare in those communities goes up. It becomes a resource. We have more urgency for more participation by minority groups. And then we're going to talk a lot more in depth about prediabetes and some of the new tools. Is it time for prediabetes to go? I think so. I mean, there are several of us on the call with it. okay? But we can go into more depth about that. Diabetes and pregnancy. We're going to talk about a lot more stuff in the future. I leave you with thank you for being here, and there's more to come. You've been very patient. Thank you very much. Dr. Reynolds, I turn it back to you.
Okay, great. Really great job, Dr. Gavin, but I expected nothing but the best. You brought it certainly with you this morning. Let me say this, guys. We have a total of 22 webinars to give. And certainly Dr. Gavin and myself and others will be doing the I guess cardiovascular one with the heart attacks and strokes, heart failures. And I guess we're going to be doing kidney failure also, but as we talked about, Dr. Gavin had mentioned, these are all kind of like running together like brothers and sisters. Diabetes and cardiovascular, they all run together, it seems like. So Dr. Gavin, we will be doing at least 10 more, maybe a little bit more focus on specific type things that you want to discuss, right? Now, Dr. Gavin did mention that there's companies that would love to let people get involved in the communities, such as our communities, and certainly Abbott is someone that I know Dr. Gavin did not mention Abbott, but I certainly got something from Abbott, shared it with a few of our inner core members, and they really want to sit down with us to talk about ways in which we can get together and do what is called it's not a feasibility thing. It's more of a help me out, Dr. Gavin. It's a pilot.
Yeah, pilot study. Yeah,
Doing a pilot study, right? So we're about ready to jump into that. So we got a lot of things going. Thanks, Dr. Gavin. But I got to tell you guys, we are so blessed and fortunate to have such a giant in this part of medicine. And when I was at church last Sunday at Antioch, heard Pastor Jackson III say that they wanted people to come out, listen to, and see. He called you the Michael Jordan of diabetes. So you definitely did not disappoint. A couple of announcements. Next week, we have Justin Reynolds along with Dr. Cadella. They'll be talking about lifestyles, exercise. So we'll get into Justin's gym in terms of working out and those kind of things. So it's very important. And as you notice, that's one of the very baseline. It's one of the bottom of the pyramid, right? So it's very important to make sure that you guys are on that. Dr. Cadella, I mean, she's absolutely fabulous. Not only is she into clinical pharmacology, but she's also into the holistic part of medicine and or science. So she'll talk about some of the different things as well. That'll be happening next Saturday. And I'm not sure if it is better for us to send these out the day before, that's the invites the day before, or maybe a couple of days before. I'm not really sure about that, but we'll work on that. On the call, we had up to 54 calls, I should say, on the actual webinar itself, but we had 100 and turned out to be 31 registrants. Nice thing about this, guys, is that we get credit for it because they will be getting the actual recording of Dr. Gavin's webinar. The nice thing about it is that this is put into like an archive, right? So it's always going to be available. So if you missed something, if someone else did not attend for whatever the reasons are, they're able to call it up, look it up, and they can hear the entire
Dr. Reynolds.
by Dr. Gavin. Yes, go ahead.
Yes, sorry to interrupt, but I did, before everyone starts leaving the presentation, I did want to share the two medications that we were talking about, the main medications, GLP-1 receptor agonist and SGLT2s. They're very expensive, of course, because they just came out on the market, rather recently. So they're still on their patent being produced by one manufacturer. And so these medications can be inaccessible for a lot of our communities, especially low income people that are, 300% below the federal poverty level, 400% below the federal poverty level, especially our Medicare patients. So I did want to mention that these medications have patient assistance programs that you can apply for if you have a high copay. And a high copay can be anywhere between $50 to $200 a month for these medications. So especially for our Medicare patients, especially when they hit the donut hole and their copay goes significantly high, probably usually that happens by midway the year. Please keep in mind that you can switch to a patient assistance program so that you can get these medications for free through the patient assistance programs. You just have to talk to your doctor about it, and then you can download the form online. You can just put the name of the medication and then put patient assistance program form, and then bring that to the next doctor's appointment, have the doctor sign their section, and then submit that along with like income evidence. And I'd be happy to assist anyone in the community that needs help applying this. I do this every day, all day, so that make sure that you get these medications, especially in the population that really needs it, that has all these comorbidities, and we need to prevent them from getting worse.
Great. Okay, Pastor Philpott, I guess we get ready to have our concluding prayer here. But again, I want to thank everybody again for making this a reality, and we look forward to the continued success of the webinar. Pastor Philpott.
Thank you, Doctor. God, we thank you, we thank you, we thank you for information. We thank you for education. And now we pray that you give us an unction to use discipline and apply what we have received today from Dr. Gavin, Dr. Reynolds, Dr. Cadelia, Dr. Moyes, all of these servants that you put in the kingdom. Thank you, God, in Jesus' name. Amen.